Chapter 103. Arterial blood pressure, definitions and normal values. Arterial blood pressure is defined as the lateral pressure exerted by the column of blood on wall of arteries. The pressure is exerted when blood flows through the arteries. Generally, the term blood pressure refers to arterial blood pressure. Arterial blood pressure is expressed in four different terms: systolic blood pressure, diastolic blood pressure, pulse pressure, mean arterial blood pressure, systolic blood pressure. Systolic blood pressure, systolic pressure, is defined as the maximum pressure exerted in the arteries during systole of heart. Normal systolic pressure, 120 mm Hg, 110 mm Hg to 140 mm Hg. Diastolic blood pressure. Diastolic blood pressure, diastolic pressure, is defined as the minimum pressure exerted in the arteries during diastole of heart. Normal diastolic pressure, 80 mm Hg, 60 mm Hg to 80 mm Hg. Pulse pressure. Pulse pressure is the difference between the systolic pressure and diastolic pressure. Normal pulse pressure, 40 mm Hg, 120 to 80 equals 40. Mean arterial blood pressure. Mean arterial blood pressure is the average pressure existing in the arteries. It is not the arithmetic mean of systolic and diastolic pressures. It is the diastolic pressure plus 1/3 of pulse pressure. To determine the mean pressure, diastolic pressure is considered than the systolic pressure. It is because the diastolic period of cardiac cycle is longer, 0.53 second, than the systolic period, 0.27 second. Normal mean arterial pressure, 93 mm Hg, 80 plus 13 equals 93. Formula to calculate mean arterial blood pressure: mean arterial blood pressure equals diastolic pressure plus 1/3 of pulse pressure. Blood pressure is altered in physiological and pathological conditions. Systolic pressure is subjected for variations easily and quickly, and its variation occurs in a wider range. Diastolic pressure is not subjected for easy and quick variations, and its variation occurs in a narrow range. Physiological variations. Age. Arterial blood pressure increases as age advances. Systolic pressure in different age. Newborn, 70 mm Hg. After 1 month, 85 mm Hg. After 6 months, 90 mm Hg. After 1 year, 95 mm Hg. At puberty, 120 mm Hg. At 50 years, 140 mm Hg. At 70 years, 160 mm Hg. At 80 years, 180 mm Hg. Diastolic pressure in different age. Newborn, 40 mm Hg. After 1 month, 45 mm Hg. After 6 months, 50 mm Hg. After 1 year, 55 mm Hg. At puberty, 80 mm Hg. At 50 years, 85 mm Hg. At 70 years, 90 mm Hg. At 80 years, 95 mm Hg. Sex. In females, up to the period of menopause, arterial pressure is 5 mm Hg, less than in males of same age. After menopause, the pressure in females becomes equal to that in males of same age. Body build. Pressure is more in obese persons than in lean persons. Diurnal variation. In early morning, the pressure is slightly low. It gradually 40 equals 80 plus 3 equals 93.3 mm Hg. Increases and reaches the maximum at noon. It becomes low in evening. After meals. Arterial blood pressure is increased for few hours after meals due to increase in cardiac output. During sleep. Usually, the pressure is reduced up to 15 to 20 mm Hg during deep sleep. However, it increases slightly during sleep associated with dreams. Emotional conditions. During excitement or anxiety, the blood pressure is increased due to release of adrenaline. After exercise. After moderate exercise, systolic pressure increases by 20 to 30 mm Hg above the basal level due to increase in rate and force of contraction and stroke volume. Normally, diastolic pressure is not affected by moderate exercise. It is because, the diastolic pressure depends upon peripheral resistance, which is not altered by moderate exercise. After severe muscular exercise, systolic pressure rises by 40 to 50 mm Hg above the basal level. But, the diastolic pressure reduces because the peripheral resistance decreases in severe muscular exercise. More details are given in Chapter 117. Pathological variations. Pathological variations of arterial blood pressure are hypertension and hypotension. Refer Applied Physiology of this chapter for details. Determinants of arterial blood pressure, factors maintaining arterial blood pressure. Some factors are necessary to maintain normal blood pressure. These factors are called local factors, mechanical factors, or determinants of blood pressure, Table 103.1. Types of local factors. Local factors are divided into two types: central factors, which are pertaining to the heart, cardiac output, heart rate. Peripheral factors, which are pertaining to blood and blood vessels, peripheral resistance. Blood volume. Blood volume. Blood pressure is directly proportional to blood volume. Blood volume maintains the blood pressure through the venous return and cardiac output. If the blood volume increases, there is an increase in venous return and cardiac output, resulting in elevation of blood pressure, Fig. 103.1. Venous return. Blood pressure is directly proportional to venous return. When venous return increases, there is an increase in ventricular filling and cardiac output, resulting in elevation of arterial blood pressure. Elasticity of blood vessels. Blood pressure is inversely proportional to the elasticity of blood vessels. Due to elastic property, the blood vessels are diastable and are able to maintain the pressure. When the elastic property is lost, the blood vessels become rigid, arteriosclerosis, and pressure increases as in old age. Deposition of cholesterol, fatty acids, and calcium ions produce rigidity of blood vessels and atherosclerosis, leading to increased blood pressure. Velocity of blood flow. Pressure in a blood vessel is directly proportional to the velocity of blood flow. If the velocity of blood flow increases, the resistance is increased. So, the pressure is increased. Diameter of blood vessels. Arterial blood pressure is inversely proportional to the diameter of blood vessel. If the diameter decreases, the peripheral resistance increases, leading to increase in the pressure. Viscosity of blood. Arterial blood pressure is directly proportional to the viscosity of blood. When viscosity of blood increases, the frictional resistance is increased and this increases the pressure. Regulation of arterial blood pressure. Arterial blood pressure varies even under physiological conditions. However, immediately it is brought back to normal level because of the presence of well-organized regulatory mechanisms in the body. Body has 4 such regulatory mechanisms to maintain the blood pressure within normal limits. Fig. 103.2. Nervous mechanism or short-term regulatory mechanism. Renal mechanism or long-term regulatory mechanism. Hormonal mechanism. Local mechanism. Nervous mechanism for regulation of blood pressure, short-term regulation. Nervous regulation is rapid among all the mechanisms involved in the regulation of arterial blood pressure. When the pressure is altered, nervous system brings the pressure back to normal within few minutes. Although nervous mechanism is quick in action, it operates only for a short period and then it adapts to the new pressure. Hence, it is called short-term regulation. The nervous mechanism regulating the arterial blood pressure operates through the vasomotor system. Situation. Peripheral chemoreceptors are situated in the carotid body and aortic body, Chapter 101. Nerve supply. Refer Chapter 101 and Figure 101.3. Function. Peripheral chemoreceptors are sensitive to lack of oxygen, excess of carbon dioxide and hydrogen ion concentration in blood. Whenever blood pressure decreases, blood flow to chemoreceptors decreases, resulting in decreased oxygen content and excess of carbon dioxide and hydrogen ion. These factors excite the chemoreceptors, which send impulses to stimulate vasoconstrictor center. Blood pressure rises and blood flow increases. Chemoreceptors play a major role in maintaining respiration rather than blood pressure, Chapter 126. Sino-Aortic mechanism. Mechanism of action of baroreceptors and chemoreceptors in carotid and aortic region constitute sino-aortic mechanism. Nerves supplying the baroreceptors and chemoreceptors are called buffer nerves because these nerves regulate the heart rate, Chapter 101, blood pressure and respiration, Chapter 126. Higher centers. Vasomotor center is also controlled by the impulses from the two higher centers in the brain cerebral cortex. Area 13 in cerebral cortex is concerned with emotional reactions. During emotional conditions, this area sends impulses to vasomotor center. Vasomotor center is activated, the vasomotor tone is increased and the pressure rises. Hypothalamus. Stimulation of posterior and lateral nuclei of hypothalamus causes vasoconstriction and increase in blood pressure. Stimulation of preoptic area causes vasodilatation and decrease in blood pressure. Impulses from hypothalamus are mediated via vasomotor center. Respiratory centers. During the beginning of expiration, arterial blood pressure increases slightly, i.e. by 4 to 6 mm Hg. It decreases during later part of expiration and during inspiration because of two factors: radiation of impulses from respiratory centers towards vasomotor center at different phases of respiratory cycle, pressure changes in thoracic cavity, leading to alteration of venous return and cardiac output. Renal mechanism for regulation of blood pressure, long-term regulation. Kidneys play an important role in the long-term regulation of arterial blood pressure. When blood pressure alters slowly in several days/months/years, the nervous mechanism adapts to the altered pressure and loses the sensitivity for the changes. It cannot regulate the pressure anymore. In such conditions, the renal mechanism operates efficiently to regulate the blood pressure. Therefore, it is called long-term regulation. Kidneys regulate arterial blood pressure by two ways: by regulation of ECF volume, through renin-angiotensin mechanism, by regulation of extracellular fluid volume. When the blood pressure increases, kidneys excrete large amounts of water and salt, particularly sodium, by means of pressure diuresis and pressure natriuresis. Pressure diuresis is the excretion of large quantity of water in urine because of increased blood pressure. Even a slight increase in blood pressure doubles the water excretion. Pressure natriuresis is the excretion of large quantity of sodium in urine. Because of diuresis and natriuresis, there is a decrease in ECF volume and blood volume, which in turn brings the arterial blood pressure back to normal level. When blood pressure decreases, the reabsorption of water from renal tubules is increased. This in turn increases ECF volume, blood volume, and cardiac output, resulting in restoration of blood pressure. Through renin-angiotensin mechanism. Source of renin secretion, formation of angiotensin and conditions when renin is secreted are described in Chapter 50. Actions of angiotensin II. When blood pressure and ECF volume decrease, renin secretion from kidneys is increased. It converts angiotensin O again into angiotensin I. This is converted into angiotensin II by ACE, angiotensin converting enzyme. Angiotensin II acts in two ways to restore the blood pressure. It causes constriction of arterioles in the body so that the peripheral resistance is increased and blood pressure rises. In addition, angiotensin II causes constriction of afferent arterioles in kidneys, so that glomerular filtration reduces. This results in retention of water and salts, increases ECF volume to normal level. This in turn increases the blood pressure to normal level. Simultaneously, angiotensin II stimulates the adrenal cortex to secrete aldosterone. This hormone increases reabsorption of sodium from renal tubules. Sodium reabsorption is followed by water reabsorption, resulting in increased ECF volume and blood volume. It increases the blood pressure to normal level, Fig 103.4. Actions of angiotensin III and angiotensin IV. Like angiotensin II, the angiotensins III and IV also increase the blood pressure and stimulate adrenal cortex to secrete aldosterone, Chapter 50. Hormonal mechanism for regulation of blood pressure. Many hormones are involved in the regulation of blood pressure. Hormones, which increase or decrease the arterial blood pressure, are listed in Table 103.2. Hormones which increase blood pressure. Hormones, which increase the arterial blood pressure, have different mechanism of action. Adrenaline. Adrenaline is secreted by the adrenal medulla. It is also released by sympathetic postganglionic nerve endings. Adrenaline regulates the blood pressure by acting through heart and blood vessels. It increases systolic pressure by increasing the force of contraction of the heart and cardiac output. It decreases diastolic pressure by reducing the total peripheral resistance. Adrenaline causes constriction of blood vessels through alpha receptors. It also causes dilatation of blood vessels through beta-2 receptors in some areas of the body like skeletal muscle, liver, and heart. So, the total peripheral resistance is reduced, leading to decrease in diastolic pressure, Chapter 71. Noradrenaline. Noradrenaline is secreted by the adrenal medulla. It is also released by sympathetic postganglionic nerve endings. Noradrenaline increases diastolic pressure due to its general vasoconstrictor effect, Chapter 71. It has stronger effects on blood vessels than on the heart. It causes constriction of all blood vessels throughout the body via alpha receptors. So it is called general vasoconstrictor. The action of noradrenaline is to increase the total peripheral resistance and diastolic pressure. It also increases the systolic pressure slightly, by increasing the force of contraction of heart. Thyroxine. Thyroxine secreted from thyroid gland increases systolic pressure but decreases the diastolic pressure. It increases the systolic pressure by increasing cardiac output. The cardiac output is increased because of increase in the blood volume and force of contraction of the heart, Chapter 67. Thyroxine has indirect action on diastolic pressure. Large quantities of metabolites are produced during increased metabolic activity induced by thyroxine. These metabolites cause vasodilatation, leading to decrease in peripheral resistance. It causes decrease in diastolic pressure. Generally, mean arterial pressure is not altered by the activity of thyroxine. Systolic pressure is increased and the diastolic pressure is decreased. So, only the pulse pressure increases. Aldosterone. Aldosterone is secreted from adrenal cortex. It causes retention of sodium and water and thereby, increases the ECF fluid volume and blood volume, leading to increase in blood pressure. Thus, an increase in the secretion of aldosterone increases the blood pressure by increasing the blood volume, Chapter 70. Vasopressin. Vasopressin or ADH, which is secreted by posterior pituitary, has a potent action on the blood vessels, particularly the arteries. It causes constriction of the arteries in all parts of the body. Due to the vasoconstriction, the blood pressure is increased. However, the amount of this hormone required to cause the vasopressor effect is very much higher than the amount required to cause the antidiuretic effect, Chapter 66. Angiotensins. Angiotensin II, III, and IV, which are obtained from angiotensin I, cause constriction of systemic arterioles and elevate blood pressure, Chapter 50. Serotonin. Serotonin is otherwise known as 5-hydroxytryptamine. Serotonin is secreted from many sources, refer Chapter 73 for details. It increases the blood pressure by vasoconstriction. Acetylcholine. Acetylcholine is the cholinergic neurotransmitter released from many sources, Chapter 73. Acetylcholine causes vasodilatation and decreases the blood pressure. Atrial natriuretic peptide. Atrial natriuretic peptide, ANP, is a hormone secreted by the atrial musculature of heart. It causes dilatation of blood vessels and decreases the blood pressure, Chapter 72. Brain natriuretic peptide. Brain natriuretic peptide, BNP, is a hormone secreted by the atrial musculature of heart. Like ANP, this hormone also causes dilatation of blood vessels and decreases the blood pressure, Chapter 72. C-type natriuretic peptide. C-type natriuretic peptide, CNP, is secreted by several tissues including myocardium and vascular endothelium, Chapter 71. CNP decreases blood pressure by vasodilatation. Local mechanism for regulation of blood pressure. In addition to nervous, renal, and hormonal mechanisms, some local substances also regulate the blood pressure. The local substances regulate the blood pressure by vasoconstriction or vasodilatation. Local vasoconstrictors. Local vasoconstrictor substances are derived from vascular endothelium. These substances are called endothelium-derived constricting factors, EDCF. Common EDCF are endothelins, ET, which are peptides with 21 amino acids. Three types of endothelins ET1, ET2, and ET3 are identified so far. Endothelins are produced by stretching of blood vessels. These peptides act by activating phospholipase, which in turn activates prostacyclin and thromboxane A2. These two substances cause constriction of blood vessels and increase the blood pressure. Local vasodilators. Local vasodilators are of two types: vasodilators of metabolic origin, vasodilators of endothelial origin. Vasodilators of metabolic origin. Vasodilators of metabolic origin are carbon dioxide, lactate, hydrogen ions, and adenosine, Table 103.3. Vasodilators of endothelial origin. Nitric oxide, NO, is an endothelium-derived relaxing factor, EDRF. It is synthesized from arginine. Nitric oxide synthesis is stimulated by acetylcholine, bradykinin, VIP, substance P, and platelet breakdown products. As nitric oxide is a vasodilator, deficiency of this leads to constant vasoconstriction and hypertension. Other functions of nitric oxide are penile erection with vasodilatation and engorgement of corpora cavernosa, activation of macrophages in brain, destruction of cancer cells and relaxation of smooth muscles of gastrointestinal tract. Types of nitric oxide. NO3, nitrate. NO+, nitrosinium cation. NO, nitroxyl anion. Measurement of arterial blood pressure. Blood pressure was first measured in horse in 1733, by Stephen Hales, with a long tube of about 9 feet length. Later, Poiseuille reduced the length of the tube to 1 foot and used mercury to balance the column of blood. In 1847, Ludwig placed a float on the top of mercury column and made continuous recording possible. Introduction of rubber tubing, anesthesia, and manometer enabled the accurate measurement of blood pressure. Blood pressure is measured by two methods: direct method, indirect method. Direct method. Direct method to measure arterial blood pressure is employed only in animals. Animal is given suitable anesthesia, then the neck is opened and a tracheal cannula is inserted into the trachea. This tracheal cannula is connected to a respiratory pump, so that the respiration in the animal is controlled artificially to avoid any disturbance during the experimental procedure. A venous cannula is inserted through the femoral vein. It is used to infuse saline to compensate blood loss during experimental procedure. Carotid artery is cannulated and connected to a mercury manometer. By using a kymograph, the blood pressure can be recorded continuously in the form of graph. The cannula inserted into carotid artery can also be connected to an electronic pressure transducer, which in turn is connected to a recording device like polygraph to obtain the recordings. Indirect method. Indirect method is used to measure arterial blood pressure in man as well as in animals. Apparatus. Apparatus used to measure blood pressure in human beings is called sphygmomanometer. Along with sphygmomanometer, stethoscope is also necessary to measure blood pressure. Principle. When an external pressure is applied over the artery, the blood flow through it is obstructed, and the pressure required to cause occlusion of blood flow indicates the pressure inside the vessel. Procedure. Brachial artery is usually chosen because of convenience. The arm cuff of sphygmomanometer is tied around upper arm, above the cubital fossa. Cuff should not be too tight or too loose. It is connected to sphygmomanometer. Now, blood pressure can be measured by three methods: palpatory method, auscultatory method, oscillatory method. Palpatory method. First, the radial pulse is felt. While feeling the pulse, pressure is increased in the cuff by inflating air into it, with the help of a hand pump. While doing this, mercury column in the sphygmomanometer shows the pressure in the cuff. When pressure is increased in the arm cuff, brachial artery is compressed and blood flow is obstructed. So, radial pulse disappears. When radial pulse disappears, the pressure is further increased by about 20 mm Hg. Then, the pressure in the cuff is slowly reduced by releasing the valve of the hand pump, i.e. the cuff is deflated slowly. This is done by feeling the pulse and simultaneously watching the mercury column in the apparatus. Pressure is noted when the pulse reappears. This pressure indicates the systolic pressure. Disadvantage of palpatory method is that the diastolic pressure cannot be measured. Auscultatory method. Auscultatory method is the most accurate method to determine arterial blood pressure. After determining the systolic pressure in palpatory method, the pressure in the cuff is raised by about 20 mm Hg above that level, so that the brachial artery is occluded due to compression. Now, the chest piece of the stethoscope is placed over the antecubital fossa and the arm cuff is slowly deflated. While doing so, series of sounds are heard through the stethoscope. These sounds are known as Korokov Sounds, named after the discoverer Korokov, 1905. While reducing the pressure, Korokov sounds have 5 phases. First phase, appearance of tapping sound. While decreasing the pressure from arm cuff, the occlusion of the artery is relieved, and when blood starts flowing through the artery, first sound appears suddenly. In a normal person, it appears when the pressure is reduced to 120 mm Hg. It is a clear tapping sound. Appearance of tapping sound indicates systolic pressure. When the pressure is reduced further by 10 mm Hg from the initial level, this sound slowly becomes louder. Second phase, appearance of murmuring sound. Following the clear tapping sound, a murmuring sound is heard when the pressure is reduced further by about 15 mm Hg. Third phase, appearance of gong sound. After the murmuring sound, a very clear and louder sound is heard. It is of gong type. It is heard while reducing the pressure by another 15 mm Hg. Fourth phase, appearance of muffled sound. Next to the gong type sound, a mild and muffled sound is heard when the pressure is decreased further by 5 mm Hg. Fifth phase, disappearance of muffled sound. Muffling sound disappears. Disappearance of this sound indicates diastolic pressure. Thus, in auscultatory method, the appearance of clear tapping sound during first phase indicates the systolic pressure, and disappearance of the muffling sound in fifth phase shows diastolic pressure. Oscillatory method. When pressure in the arm cuff is increased above the level of systolic pressure, the artery is occluded due to compression. At this stage, the mercury column in the manometer remains static. When the pressure is gradually reduced, some oscillations occur at the top of the mercury column. While deflating the cuff further, the amplitude and duration of oscillations increase suddenly. It denotes systolic pressure. When the cuff pressure is reduced further, the amplitude and duration of oscillations is reduced. It reflects the diastolic pressure. Because of its inaccuracy, This method is not followed in routine clinical practice. By connecting the manometer to an appropriate recording device, the oscillations of mercury column can be recorded graphically. Automatic blood pressure instrument. Nowadays, automatic blood pressure instrument is widely used. The instrument has a microprocessor-driven air pump, which automatically inflates the arm cuff at a fixed pressure value. Then, it records the pressure oscillation pattern during a stepwise deflation. The principle of measuring pressure depends upon the nonlinear properties of brachial arterial wall, which induce non-constant oscillations of the cuff pressure during deflation. The sensors in the instrument detect the oscillometric waves and determine the systolic pressure, diastolic pressure, pulse pressure, and mean arterial pressure. The instrument determines the pulse rate also. Automatic instrument does not need expert personnel to measure the blood pressure since it has the self-measuring facilities. However, the accuracy of oscillometric method is still controversial. Microprocessor-controlled blood pressure monitors that are fixed around wrist or finger are also available. Applied physiology. Pathological variations of arterial blood pressure, hypertension. Hypotension. Hypertension. Definition. Hypertension is defined as the persistent high blood pressure. Clinically, when the systolic pressure remains elevated above 150 mm Hg and diastolic pressure remains elevated above 90 mm Hg, it is considered as hypertension. If there is increase only in systolic pressure, it is called systolic hypertension. Types of hypertension. Hypertension is divided into two types: primary hypertension or essential hypertension. Secondary hypertension. Primary hypertension or essential hypertension. Primary hypertension is the elevated blood pressure in the absence of any underlying disease. It is also called essential hypertension. Arterial blood pressure is increased because of increased peripheral resistance, which occurs due to some unknown cause. Primary hypertension is of two types: benign hypertension, malignant hypertension. Benign hypertension. Benign hypertension is the high blood pressure that does not cause any problem. It is defined as the essential hypertension that runs a relatively long and symptomless course. In early stages of this condition, there is moderate increase in blood pressure, with systolic pressure of 200 mm Hg and the diastolic pressure of about 100 mm Hg. However, in resting conditions and sleep, the blood pressure returns to normal level. Later, there is a further increase in blood pressure and it does not come back to normal level in resting conditions. Persistent increase in pressure over the years causes development of vascular, cardiac, or renal diseases. Malignant hypertension. Malignant hypertension is a severe form of hypertension with a rapid course leading to progressive cardiac and renal diseases. It is also called accelerated hypertension. In this case, the blood pressure is elevated to a great extent. Systolic pressure rises to about 250 mm Hg and diastolic pressure rises to 150 mm Hg. It is always developed due to the combined effects of primary and secondary hypertension. Malignant hypertension causes severe damage of tunica intima of small blood vessels and organs like eye, retina, heart, brain, and kidneys. It is a fatal disease, since it causes death within few years. Secondary hypertension. Secondary hypertension is the high blood pressure due to some underlying disorders. The different forms of secondary hypertension are: cardiovascular hypertension. Cardiovascular hypertension is produced due to the cardiovascular disorders such as atherosclerosis, hardening of blood vessels due to fat deposition, coarctation of aorta, narrowing of aorta. Endocrine hypertension. Endocrine hypertension is developed because of hyperactivity of some endocrine glands, pheochromocytoma, tumor in adrenal medulla, resulting in excess secretion of catecholamines, hyperaldosteronism, excess secretion of aldosterone from adrenal cortex, Cushing's syndrome, excess secretion of glucocorticoids from adrenal cortex. Renal hypertension. Renal diseases causing hypertension, stenosis of renal arteries. Tumor of juxtaglomerular cells, leading to excess production of angiotensin II. Glomerulonephritis. Neurogenic hypertension. Nervous disorders producing hypertension, increased intracranial pressure. Lesion in tractus solitaris. Sectioning of nerve fibers from carotid sinus. Hypertension during pregnancy. Some pregnant women develop hypertension because of toxemia of pregnancy. Arterial blood pressure is elevated by the low glomerular filtration rate and retention of sodium and water. It may be because of some autoimmune processes during pregnancy or release of some vasoconstrictor agents from placenta or due to the excessive secretion of hormones causing rise in blood pressure. Hypertension is associated with convulsions in eclampsia, Chapter 84. Experimental hypertension. Hypertension can be produced in experimental animals by various methods. These methods correlate with the causes of hypertension in human beings. Experimental hypertension is produced by the following methods: clamping the renal artery, denervation of baroreceptors in carotid sinus and aortic arch, injections of corticosteroids, infusion of salt with aldosterone. Goldblatt hypertension. Goldblatt hypertension is one of the experimental hypertension produced in dogs by Goldblatt, and it is named after him. He removed one kidney of the dog and clamped the artery of other kidney. It produced slow and steady increase in arterial pressure. The elevation of blood pressure was due to excessive secretion of renin from intact kidney, leading to the formation of a large quantity of angiotensin II. It is known as one-kidney Goldblatt hypertension. Hypertension is also developed when the artery of one kidney is clamped without doing anything with the kidney of the other side. It is called two-kidney Goldblatt hypertension. It is due to the renin-angiotensin mechanism and retention of salts. Manifestations of hypertension. Severe manifestations of primary hypertension: renal failure, left ventricular failure, myocardial infarction, cerebral hemorrhage, retinal hemorrhage. Treatment of hypertension. Secondary hypertension is cured by treating the disease causing hypertension. Primary hypertension can be controlled but cannot be cured. Following are the antihypertensive drugs to control primary hypertension: beta-adrenoceptor blockers. Beta-adrenoceptor blockers or beta antagonists, adrenergic beta blockers or beta blockers, block the effect of sympathetic nerves on heart and blood vessels by binding with beta-adrenoceptors, so that there is reduction in cardiac output and inhibition of vasoconstriction, leading to fall in blood pressure. Alpha-adrenoceptor blockers. Alpha-adrenoceptor blockers or alpha antagonists, adrenergic alpha blockers or alpha blockers, block the effect of sympathetic nerves on blood vessels by binding with alpha-adrenoceptors, leading to vasodilatation and fall in blood pressure. Calcium channel blockers. Calcium channel blockers are drugs, which block the calcium channels in myocardium and thereby, reduce the contractility of myocardium. It causes decrease in cardiac output and fall in blood pressure. Vasodilators. Vasodilator agents reduce blood pressure by vasodilatation. Diuretics. Diuretics cause diuresis and reduce the ECF volume and blood volume. So, blood pressure is decreased. Inhibitors of angiotensin converting enzyme, ACE inhibitors. ACE inhibitors reduce the blood pressure by blocking the formation of angiotensin. Depressors of vasomotor center. Depressor drugs act on vasomotor center and reduce the vasomotor tone. So, vasoconstriction is prevented. Angiotensin II receptor blockers. Angiotensin II receptor blockers or antagonists are the antihypertensive drugs that decrease the blood pressure by blocking the effect of angiotensin II, vasoconstriction and secretion of aldosterone. Hypotension. Definition. Hypotension is the low blood pressure. When the systolic pressure is less than 90 mm Hg, it is considered as hypotension. Types. Primary hypotension. Secondary hypotension. Primary hypotension. Primary hypertension is the low blood pressure that develops in the absence of any underlying disease and develops due to some unknown cause. It is also called essential hypertension. Frequent fatigue and weakness are the common symptoms of this condition. However, the persons with primary hypertension are not easily susceptible to heart or renal disorders. Secondary hypertension. Secondary hypertension is the hypertension that occurs due to some underlying diseases. Diseases, which cause hypertension are, myocardial infarction, hypoactivity of pituitary gland, hypoactivity of adrenal glands, tuberculosis, nervous disorders, orthostatic hypertension. Orthostatic hypertension is the sudden fall in blood pressure while standing for some time. It is due to the effect of gravity. It develops in persons affected by myasthenia gravis or some nervous disorders like tabes dorsalis, syringomyelia, and diabetic neuropathy. Common symptom of this condition is orthostatic syncope. Syncope is described in detail in Chapter 116.